This is The Other Side of Midnight. I'm Frank Morano. Well, there's no greater philanthropist than Mike Bloomberg, maybe in the entire world. The guy gives hundreds of millions, the guy gives billions of dollars to various charities, and clearly he's always had a soft spot for Johns Hopkins. And a big part of his recent donation of $600 million was not to Johns Hopkins, but to 4 historically black medical schools. Why? Well, according to Mayor Mike Bloomberg, research shows that a lack of black doctors helps explain why black people tend to die younger than their white peers. I've seen this article and I've seen this research reported again and again. Basically, it suggests that black patients, when they're treated by black doctors, have better health outcomes. And I guess the thinking goes there's a variety of reasons for that. Here is someone who completely rejects that hypothesis, and I must say wrote a very persuasive op-ed on this subject in the New York Post recently. Dr. Stanley Goldfarb is the chairman of Do No Harm. He's also a nephrologist and a former associate dean of the Perelman School of Medicine at the University of Pennsylvania. Dr. Goldfarb, thanks so much for joining me on the radio.
Great to be with you, Frank.
So let's begin with your group, Do No Harm. What exactly is Do No Harm? What do you guys do?
Well, we're a group that's, our mission is to combat all discriminatory practices in medicine. We want to see every patient treated as an individual. We reject identity politics in all of its forms. And we're also very much, as a secondary mission, very much opposed to so-called gender-affirming care for children. We make no position about adults, but we're mainly interested in fighting against all these discriminatory practices and the racialization of healthcare.
I want to come back to the gender-affirming care if we have time, because that's obviously been a very controversial issue, and I want to spend most of our discussion focusing on your op-ed. But when it comes to identity politics and so forth, there was a similar study, maybe I saw it about 3 or 4 months ago, that showed female doctors had better outcomes when treating their patients, not just female patients, but all patients, especially female patients. Did you buy that at all?
Well, I'm not familiar with that study. The thing that's very difficult to get at is the outcome. So the idea that somebody decides, well, somebody is going to like their doctor and that therefore they're going to have a better health outcome is something that our group has looked at very carefully. We've looked at the data with respect to so-called racial concordance when black patients have black doctors. And the issue has been, are there any data that really show that, in fact, the outcomes are better? Now, outcomes are very hard to measure in medicine. Usually they use some sort of surrogate. For example, did the patients find that the communications were better? Or did the patients fill more prescriptions when they had a doctor that was in the same race as they were? And it turns out there were over 60 studies of this issue in the medical literature. And our group and I have looked at this body of literature very carefully. And in fact, there are no data to show that black patients have better outcomes when they have a black doctor. They don't even, the literature doesn't even support the idea that there's better communication, that the patients, in fact, feel better with their physician if the physician is of the same race. And our group has even done a survey of over 800 black adults and asked them the question, are you more interested in that your physician looks like you or that you have the most qualified physician? And over 80% said no, they want the most qualified physician. So this idea that black patients even necessarily want black doctors isn't really confirmed, but certainly the evidence that black patients will have better health outcomes, will be healthier, will have no evidence of healthcare disparities, which we know are a real phenomena that do exist. There's no evidence that having racial concordance is going to improve any of that. And when you really think about it, there's no real particular reason that it should. Mm-hmm. The issue should be, do you have the best doctor? Do you have a highly knowledgeable doctor? Do you have a doctor that's applying the best medical care in your particular case. That's what really counts. And, Black patients want the best doctor.
All right. So you argue that the idea of racial concordance in medicine is a lie that can harm patient care. However, some studies suggest that shared cultural and racial backgrounds can improve patient-physician communication and trust. How do you reconcile those findings with your position?
I think if you look carefully at those studies, and our group has done that, our group has looked at every study that's out there. And now not only have we looked at every study that's out there, there are 5 studies that are so-called systematic reviews of this issue. And if you look at those studies, which have aggregated all these studies together and looked at them together, they don't find that statement is true. It just isn't. It's a myth that that's the case. Mm-hmm. There are no data that say that that's really true. For example, there's one study that said that Black doctors spent more time with their Black patients. What the data really showed was they spoke more slowly, but they didn't really say more. And again, there have been other studies that have looked at the question of whether at the end of these interactions between patient and physician, that the patients say, no, I really am more satisfied with this kind of doctor. It's just not true. It suggests that Black people are sort of racist, in fact. That's the point. And they aren't. And that's not what the data show. So these statements that go on out there, that Black patients do better with Black doctors, this would improve the health of the Black community, this is said all the time. It just doesn't have any data to really support it.
At 30 minutes after the hour, you're listening to The Other Side of Midnight. You mentioned that the psychological tests purported to show bias in medical care have been debunked. Other than your group study, can you provide specific examples of these tests and elaborate on how they've been discredited?
Sure. So one of the ways that people say, well, we've shown that there's bias in healthcare. We've shown that white doctors are biased against Black patients. And when you look at what's the evidence for that, the evidence is something called using the implicit association test. The implicit association test was developed at Harvard, actually, about 25 years ago. And it consists of showing pictures on a screen, on your computer screen, and then determining how quickly people respond when a phrase goes up on the screen to describe the picture. So, for example, they'll show a picture of a Black individual and they'll put the word handsome up. And then they'll show a picture of a white individual, a male, put the word handsome up. And how quickly you respond by pressing a button on your computer determines whether or not you're biased. Well, as silly as that sounds, and it does sound pretty silly that's going to be able to tell whether anyone's biased, if you give that same test to people on 2 separate occasions, there's less than 50% reliability between their responses. So exactly why there's a slight difference in timing when you press a button could simply be someone says, Black people have the short end of the stick. People don't think they're handsome. And as they're thinking about that might delay their pressing the button, for example. Well, this test has been debunked as being adequate to determine whether anybody is biased against anyone. And as I said, the test is not reliable when given on 2 separate occasions to the same individual. So there is no good evidence that there is systematic bias between Black patients and white physicians or vice versa. You can cherry pick a study here and there and say, well, look what this study shows. But when you look at the totality of the literature, which should always be the case in science, to make sure that things have been reproduced when someone makes a statement that a separate study confirms it, you cannot find that in this topic. And so that was our concern about Mr. Bloomberg's statement that this is going to improve health outcomes for Black individuals. It's not. And that's the problem. It's wonderful that he's philanthropic and has given money to these schools, and they're highly worthy of having support of students that have economic problems and can't pay for their medical education. But this is not the solution to having healthcare disparities between two different communities.
It really resonates with me listening to what you're talking about in saying how the assumptions that black patients do better with black doctors is almost racist. And I understand the premise of that. And your op-ed suggests that promoting racial concordance could lead to the resegregation of healthcare. That being said, do you believe there's any sort of a middle ground where diversity in the medical field can be encouraged without leading to such a division?
To tell you the truth, I don't. I think that the issue should be that we should have the best trained healthcare workforce that we can possibly find. If that healthcare workforce was all of one race, so be it. If all of the medical students at Johns Hopkins that you mentioned were also all black and they were the best individuals that were available, great. That's all. That's perfectly fine with me. The issue should be the merit of the individuals who are going into medicine, and it should be the way patients are treated as individuals. We shouldn't be treating patients because they're black or white. We should be treating patients because of their individual problems. And this identity politics, which is sort of invaded healthcare, I think is something that it leads to real problems. For example, when I was practicing medicine, and I'm retired now, I remember a patient came into our hospital, University of Pennsylvania, and said that they didn't want any black people in the room. They only wanted white doctors. And we said, well, then you ought to find a different hospital. But if you're saying we're going to set up a situation where we have race-based healthcare and some individuals are going to get to see a physician of a certain physical appearance simply on the basis of their race, A, it's illegal, and B, I think it sets a terrible example, and it undermines the kind of healthcare that people need to receive.
If you're just tuning in, I'm Frank Morano. This is The Other Side of Midnight. So Mike Bloomberg's donation is aimed at increasing the number of black doctors, which he believes will help improve health outcomes for black patients. It's clear that you don't buy into that. If not through racial concordance, what other strategies would you suggest for addressing the health disparities faced by black communities?
Yeah, I think the answer is really a better health access. And when I say that, I mean better health access that's provided to patients and better access that patients use to get to their physicians. So, for example, there was a recent article that was in the Wall Street Journal that was talking about uterine cancer, which is a terrible disease. And they pointed out the fact that there's a big discrepancy in healthcare outcomes between black and white women who have uterine cancer. It turns out that white women get to their physician within 4 months after their first symptoms, usually abnormal bleeding, that it goes along with uterine cancer. Black women were showing up 8 months after their first symptoms. And we find this over and over again. We have to have communities have awareness of clinical problems and seek help earlier than they typically do. And this, unfortunately, is a real problem. Now, is the problem with the black community for some of these illnesses, is it because of distrust that they have in the healthcare system? And if that's the case, we have to improve trust. And a good thing to do is to increase access to the patients. For example, a mobile breast cancer screening activity that should go on in the black community. This is the sort of thing that's going to improve their health outcomes. Some of the bases for abnormal health outcomes actually have a genetic basis. Some of the bases have a lifestyle basis. Some of it is due to the fact that healthcare access is delayed for these patients. Another example of this is the increased risk of leg amputations for patients that have diabetes. There's a big difference between black and white patients and the incidence of amputations for this problem. It turns out patients have to come to the healthcare system early when the first signs of these abnormalities start to appear, and not wait until the point where the only treatment possible is an amputation. And I've talked to vascular surgeons who confirm that that's almost always their assessment of the problem. So I think healthcare access is the real answer to this. And in some cases, you're going to have a genetic basis for different outcomes. One big example is in maternal mortality. There are several issues that that Black women are suffer from that have to do with not their skin color as the cause of the genetic differences, but the fact that people come from specific geographic areas and carry with them certain genetic characteristics of those areas. So it turns out, for example, that in West Africa, many enslaved people came from West Africa to this country. They brought with them certain characteristics that went along with that part of the world. One of the characteristics that you find there commonly in the Black community is a certain gene that protects against a kind of parasite that produces a form of blindness. And having that gene dramatically increases the risk of kidney disease. And if women have that gene, they are much more likely to have preeclampsia, severe hypertension during pregnancy, and have risks to have a complicated pregnancy. So that's just one example where no matter what you do, there's going to be increased risk to certain populations of people. And the answer is to get them, for example, with maternal mortality, to get them to have prenatal care in the first trimester. Black women have a 40% lower rate of getting prenatal care in the first trimester compared to white women. And that's a big cause of the discrepancy. So over and over again, you find the need for better healthcare access, better healthcare literacy in the community, and in some cases, a specific treatment that needs to be based on the patient's characteristics in order to improve outcomes.
Do you think that Bloomberg's donation, and if people are just tuning in, by the way, we're talking with Dr. Stanley Goldfarb. He's the chairman of a group called Do No Harm. Do you think that Mike Bloomberg's donation could have unintended positive effects, like maybe inspiring more young Black students to pursue careers in medicine, even if you don't agree with the premise behind it?
Sure. No, I think the philanthropy is great. I think that helping people, particularly people that have economic problems, I'm sort of opposed to scholarships sort of, broadly distributed that don't respond to the individual's need for that support. I mean, people that go into medicine make pretty good livings, and, you want to make sure that the money is given to those who have the particular economic problems. But I'm all for those medical schools. I think they should be strengthened every way possible, that the best and the brightest in the community ought to have an opportunity to be physicians. But I don't think because they're Black, they should be physicians. They should be physicians because they're capable and talented and devoted and are going to provide great medical care. That's why they should be physicians, irrespective of what their skin looks like.
No, well said. You make a very strong case. I think you've made a believer out of me. How do you think the medical schools themselves can ensure that their efforts to diversify don't compromise the quality of education and care that they're supposed to be giving?
Unfortunately, I think as soon as you decide I'm going to give someone an opportunity based on their physical appearance, on their skin color, on some immutable characteristics, almost inevitably you're going to have to sacrifice quality, because there may be someone else there who has a better academic performance and yet doesn't fit this identity that you've decided you're going to support. And therefore, you've compromised quality. And this idea that we can have both without any potential compromises just isn't the case. And I think, for example, the Students for Fair Admissions to Harvard, the famous case before the Supreme Court showed this, that in fact, if you start to go down that path, you're going to exclude people that may be more qualified. And therefore, you're going to undermine the quality of the individuals. Now, I think undergraduates, there are many different arguments that can be applied in the undergraduate realm about this, about exposing people to different cultures and different kinds of individuals. But in medical school, these are adults. They've already gone to college. They've already gone to high school. They've already been integrated into the community. At this point, the issue ought to be, how qualified are they to be physicians? The same questions ought to be raised, in pilot school. We're not trying to acculturate individuals at that point. We're trying to train people for a very important task that puts people's lives at risk. And I think when those criteria are the basis for a particular education activity, then you just can't ignore the fact that you should take the best and brightest. And no matter what they look like, no matter what their background is, you should not have someone who has greater potential being denied because of these kinds of immutable characteristics. And of course, in medicine, unlike undergraduates in college, there's only a limited number of positions. And there are 2 applicants for every spot that's available in medical schools in this country every year. So if someone's getting into a medical school, then someone else isn't. And therefore, unless you do it on the basis of the merit of the individuals, you're going to compromise quality.
Dr. Goldfarb, we're just about out of time, so let me end with this, and I hope you'll come back and we can have a lengthier discussion about gender-affirming care in general and specifically for children. But let me just ask, I happen to agree with your position completely, but critics of restricting gender-affirming care for minors have argued for a long time that delaying treatment until adulthood can lead to severe psychological distress and increased risk of self-harm. How do you feel about that? Do you give that argument any credence at all?
They just, again, I mean, this is sort of something that superficially sounds quite logical. And, if someone's going to undergo this so-called gender transition, that the earlier that it occurs, the better. The problem is, first, the data just aren't there to support this. The best study that claims that it will improve the mental health welfare of children that go through transition comes from the University of Washington. And that study really showed a very different outcome. What it showed was that children that went through the transition had absolutely no change in their mental health outcome. The control group, who for some reason did not get the hormones and the puberty blockers and so on, had a decline in their mental health well-being, except the problem was 80% of the control group dropped out. So they had no idea how 80% of the people fared in this study. And what they did show was that all of the children that got the so-called gender-affirming care really had no improvement in their mental health status. So there is no good evidence that it really improves their mental health status, and there is no evidence that it increases the risk of suicide. That's been totally debunked, that idea. And of course, it's the basis for several European countries finally deciding to start to restrict this care, because on the other hand, we do know that the so-called detransition rate, the number of children that regret this, may be as high as 30 or 40%. And so at the end of the day, when you have a treatment that's not beneficial and that it is associated with harm, the best thing to do is not to apply that treatment. And there's really no reason why children can't wait until they go through puberty, because many children who go through puberty actually change their minds. And there are several studies that show that if individuals are not treated and go through puberty, that up to 80 or 90% of them will be perfectly happy in the gender that they were born into and continue in that gender. Many of them may be gay, but they'll have perfectly normal lives. And on the other hand, if they go through hormonal treatments, puberty blockers, and even surgeries, some of this is irreversible.
Dr. Goldfarb, we'll have to end it there. Thanks for writing this op-ed. You gave me a lot to think about. And before reading it, I would have just assumed that everything that I had heard about black doctors and black patients was accurate. And I no longer have that assumption. Thanks for the conversation. I hope you'll come back.
Thank you very much, Frank. Enjoyed it.
If you want to comment on any portion of our conversation, you can give me a call. Our phone number is 646